Good afternoon, ladies and gentlemen. On behalf of the Canadian Council of the Blind's Toronto Visionary Chapter, I want to welcome you to Vision Health Month's Expo Forum. Now, before we get started, I would like to introduce and ask to stand Jim Tokas, National President of the Canadian Council of the Blind. Mr. Tokas.
Thank you, Michael. You're very kind. On behalf of the Canadian Council of the Blind, I'd like to welcome everyone, and special attention to, from the National Board, to the man who puts it all together in Toronto every year, and even questioned us about the pandemic years, but awesome to see Ian back, and thank you, Ian. This has been a wonderful, wonderful return, and thank you for all your outstanding work.
Thanks very much, Jim. It's an absolute pleasure to be here. We have spent 2 years in limbo, not being able to gather the way we have in past years, not being able to connect with our community the way we have wanted to, and we're now at a point with the relaunch of the White Cane Week Experience Expo to have the opportunity to bring our community together in person at an event where we can share the kind of information that people with vision loss need to live fuller, richer lives. And it has just been a fabulous opportunity for us to be part of making that happen. I am deeply honored and very proud of the team of people who have helped put this day together. And I'm extremely excited to be here at the forum to be one of the people in the audience who will be listening to this panel discussion today. I think the topic here is of vital importance, not just for people with vision loss, but for anyone who accesses the healthcare system in Canada. So thank you to the panelists for coming in, and thank you to you, the audience, who are in attendance today, whether in person or virtually, for lending your ears to this important discussion. Thank you so much.
Thank you, Ian. Moving along, the CCB and its members honor the Algonquin, Anishinaabe Nation, First Nations, Inuit, and Métis people, and acknowledges that Ottawa, home of our head office, is built on unceded Algonquin and Anishinaabe territory. The people of the Algonquin Nation have lived on this territory for millennium. Their culture and their presence have nurtured and continue to nurture this land. The CCB honors the people and the land of the Algonquin and Anishinaabe Nation. CCB honors all First Nations, Inuit, Métis peoples, and their valuable past and present contributions to this land here in Toronto and across Canada. Along with the Government of Canada, we at the CCB are committed to the renewed nation-to-nation relationship with Indigenous peoples based on recognition of rights, respect, cooperation, and partnership. The Canadian Council of the Blind stands with the Ukraine. Through the fog of war and amid our prayers for lasting peace, the Canadian Council of the Blind would like to express its deep concern and support for the people of Ukraine, and in particular our brothers and sisters in the blind, deafblind, and partially sighted community. This unjustified war continues to take the lives of innocent civilians, violates all norms of international and humanitarian law, and is a crime against humanity. We join the free world in condemning the violence in the Ukraine and to call on the presidents of Russia and Belarus to cease hostilities. We urge the European Union of the Blind and its members to provide all possible assistance in accommodating the refugees from Ukraine with visual disabilities. We strongly urge Russia and Belarus to respect their international obligations and ensure the protection and safety of all persons with disabilities in accessing safe evacuation and humanitarian assistance. The theme of today's Expo Forum is because knowledge leads to a better health. The panel will speak to best practices, a patient's right to informed consent, and full disclosure of whatever the treatment, including all of the informed therapies, their side effects, dosage frequency, all options, and the costs, which should never enter into what the patient is prescribed before a treatment decision is made. Above all, and maybe more importantly, empowering each of you the desire and confidence and ability to be self-aware and advocating for your own self. Let's talk a little bit about our expert panel and the role in today's Expo Forum. On my immediate left, Dr. Chad Andrews is the Director of Research and Policy at the College of Optometrists of Ontario. First up, Chad will discuss the value of regular optometric eye exams and the importance of early detection of vision issues, both from a health and economic perspective. Chad will be followed by Sarah Shephard, who is a leading patient advocate who has spent her career in health policy and partnered access function of the pharmaceutical industry, with the goal that no patient falls through the cracks. She has worked in ophthalmology with the vision loss community for over 15 years. Today, Sarah will address the question of, if you have been diagnosed and prescribed a treatment, what happens next? How do you navigate the system for yourself, your friends, and your family? Next is Dr. Keith Gordon, Senior Research Officer for the Canadian Council of the Blind. Keith is also Chair of the Boards of Balance for Blind Adults and the international organization Retina Action. Keith will discuss the need for compliance with your medications, an understanding of your eye diseases, and the medications associated with them and their possible side effects. Last but not least, John Adams is the first and foremost patient's health rights advocate. John is a co-founder and president and CEO of the Canadian PKU and Allied Disorders, a nonprofit supporting those dealing with phenylketonuria, or PKU. Today, John will stress the importance that you be a driver, not a passenger, of your health care and well-being, the cause for advocacy and self-advocacy. Ladies and gentlemen, today's panel and the focus of our topic. At the completion of the presentations, there will be a brief discussion by the panel and then followed by question and answers. With that, I would like to introduce Dr. Chad Andrews.
Thanks, Michael, and hi, everyone. As Michael mentioned, my name is Chad Andrews, and I'm a policy analyst and researcher at the College of Optometrists of Ontario. I've also worked with the Canadian Council of the Blind on various vision-related initiatives in the past, including research projects, events, and other patient-centered projects. I'd just like to open by saying thanks to Michael Belarjan, the Canadian Council of the Blind, and the Toronto Visionaries chapter for organizing this incredible event, as well as the many sponsors who supported it. I think that my fellow panelists will agree that the creation of a space for those in the vision loss and blindness community to network, to share knowledge and experiences, and to imagine new ways of living and interacting is absolutely crucial. And that's what this event is all about. So again, my sincere thanks to Michael and all of the organizers for making this happen. Now, Michael mentioned this already, but one thing that our panel is going to focus on, or one theme, is informed consent, and what that actually means in the world of healthcare delivery. In a very general and preliminary way, it's possible to say that informed consent occurs when patients are given a clear and comprehensive description of a treatment or healthcare service, as well as potential alternatives. And secondly, it occurs when they are given the opportunity to fully agree to receiving that treatment or healthcare service. So that's a very basic definition. Number one, patients are appropriately informed about a treatment and its alternatives. And number two, patients agree or disagree to receiving the treatment or service. The problem, however, is that informed consent is really more complicated than this. And we know this because hundreds, if not thousands, of papers have been published on the nature of informed consent as a principle in medical ethics. Additionally, what informed consent really means in real-world scenarios depends on context. In this case, the most meaningful context is one specific location within what health analysts sometimes call the continuum of care. So for example, informed consent means one thing, at least at the practical level, when you're having your vision tested by an optometrist, and it means something else entirely, again, from a practical perspective, when you're deciding which treatment is best for your particular eye disease, if you have one. So with that in mind, what we're going to attempt to do today is move through a basic interpretation of the continuum of care and reflect on the nature and challenges of not only informed consent, but also best practices and patient rights along the way. So that continuum will start with me. I'll discuss the value of regular eye exams and the early detection of vision issues. So in other words, what happens when you either don't have a vision issue and are focused on prevention, or when you do have a condition such as glaucoma that's being monitored through regular check-ins with your optometrist. And then we'll move over to Sarah, who will discuss issues such as prescriptions and consultations. So in other words, you've been diagnosed with a vision issue and have your prescription. Now what do you do? And what does informed consent look like at this stage? Then we'll go to Keith, who will provide an overview of issues related to adherence to medications, as well as some of the challenges presented by the COVID-19 pandemic. So you've been tested and have received your medication or directions regarding treatment. What do you do next? And how do you navigate some of the complexities of the pandemic while trying to adhere to what can sometimes be a demanding treatment regimen? And finally, we'll go over to John, who will take a step back, or at least a step outside of this continuum to some degree, to discuss the importance of patient rights and self-advocacy. Now, I should say that I put that kind of overview together, and hopefully I didn't do a disservice to my panelists, but I think that in general, that will be the kind of trajectory that we're dealing with today. We're kind of going through, like I said, a very basic interpretation of the continuum of care, starting with detection and then moving all the way to adherence and patient rights and advocacy. So it probably goes without saying that if you've received directions from your vision care provider to receive regular eye exams, then you should get them at the frequency you've been told is necessary. I mentioned glaucoma earlier, and I think that's a good example. The central component of the pathophysiology of glaucoma is intraocular pressure, or IOP, which must be monitored regularly. If your eye care professional recommends appointments every 3 weeks, then it's crucial to attend those appointments. And this is something Keith will likely touch on in relation to something called anti-VEGF medications. A point I'd also like to emphasize today, however, is the importance of having your eyes examined specifically by an optometrist, even if you're asymptomatic and don't have an existing condition. Optometrists are the frontline workers of the vision care system, and what they can do is detect complications before they become more problematic, or in the worst case, before they lead to vision loss that is irreversible. With this in mind, the Canadian Association of Optometrists used clinical evidence to recommend the following timetables for optometric eye exams, and this is for individuals with no conditions. First, infants and toddlers should undergo their first optometric age exam between the ages of 6 and 9 months. Preschool children should be examined at least once between the ages of 2 and 5. School-aged children, aged 6 to 10 years, should receive an examination annually. Adults between 20 and 39 should be examined every 2 to 3 years. Adults between 40 and 64 should be examined every 2 years. And finally, those who are 65 and older should be examined annually. Now, I mentioned that the Canadian Association of Optometrists used clinical evidence to generate those guidelines. It is also the case, however, that the general idea of the public health value of regular optometric eye exams is supported by a wide range of research. A 2010 study published in Population Health Management found that regular eye exams were instrumental in detecting the early stages of diabetes, hypertension, and high cholesterol, and that those who had these issues detected early paid lower healthcare costs, missed fewer work days, and were less likely to lose their jobs due to health complications. A 2019 study published in Public Health Review found that school-aged children in Ohio experienced better health when they received comprehensive optometric eye exams instead of the more informal, non-comprehensive screenings that are provided in some schools. And this isn't directly related to the health benefits of eye exams, but a Canadian study published in CMAJ in 2013 found that when regular eye exams were delisted from OHIP in 2004 for healthy adults between the ages of 20 and 64, it had the unintended consequence of reducing the number of OHIP-covered eye exams received by those with diabetes. Now, according to the researchers, this suggests that when specific divisions are created in the area of public coverage, it leads to confusion regarding what's covered and what's not. This is a policy issue, and it indicates that broad, universal coverage may be better for reasons that aren't necessarily obvious or directly health-related. And those are just 3 examples. Much more work has been done in this area, and overwhelmingly, the evidence shows that regular optometric eye exams not only lead to better health outcomes, but also lower downstream health system costs through the early detection and prevention of what could become complex, costly, and difficult to treat vision issues. I could talk about the value of detection and prevention for much longer, but I'd like to discuss informed consent as well, and what that looks like in this particular area. First off, and we've touched on this already, it's important to note that eye exams are not covered in Ontario for most adults between 20 and 64 years old, except in the case of certain medical conditions. For individuals who have OHIP coverage for eye exams, the coverage does not include some tests that help in the diagnosis and management of certain diseases and conditions. What this means is that in order to adhere to the principle of informed consent, optometrists will provide clear and helpful information regarding the nature of the exam as well as its benefits and risks. They do this by informing you of any test before it happens, explaining why the test is needed in your situation, outlining any additional fees and explaining what they are for, discussing the benefits or risks, if any, associated with the test, and finally, obtaining your consent to perform the test. It's also worth noting, of course, that you should feel free to talk to your optometrist about what to expect at your next eye exam. And I should also mention that the information I just provided is part of an online resource offered by the College of Optometrists of Ontario, the organization that I work for. So that's my brief overview of what informed consent should look like in the area of optometric detection and prevention. You should be aware of the test. You should know if there are additional uncovered fees and what they are for, and you should be made aware of benefits and risks. And finally, you should, of course, provide your consent. It's also beneficial, and this will be the case in the areas my fellow panelists discuss as well, to be as informed as possible about the relevant issues before you enter into a clinic or undergo a test. So I've spoken for long enough. I hope that's given you a sense of the value of optometric eye exams and the way that informed consent fits into that picture. I'll now hand it over to Sarah to discuss what happens next.
Thank you, Chad.
Yep.
Great. So once you've been to the optometrist, you may get a referral onto the ophthalmologist or a retinal surgeon. And I know that in this crowd, everybody knows who that is. And what I'm about to say really could pertain to any condition or any type of medication. The biggest thing is that things are managed on a provincial level. So the rules that happen to be running the health programs in Newfoundland are not the same as those in British Columbia and not the same as those here in Ontario where we are. But I know that this viewing audience is across the country. So what I'm about to say is if you have questions and you ever want to talk to another person in the same situation, if I call it a patient, that's habit from my background, but your friends who may have the same condition, always ask people for advice in your own province, because how anything is treated and the rules and regulations it's always different across the provinces. So that's the most important thing, and it gets really wonky the further west you go when it comes to anything with ophthalmology. But once you've had a diagnosis and perhaps a prescription written, how do you turn that piece of paper, the script, into actually getting the medicine in your hand or perhaps having the medicine injected into your eye by a retinal surgeon? in the big picture, there's two different ways you can do it if for payments. One is that you pay through your insurance, or the other is that you pay through the government. Some people don't qualify for either, and they would pay cash. But for today's examples, we'll just talk about people who have private insurance and people who are above 65, or in most provinces, social services, or there may be disability categories where the government pays for prescriptions. Starting with the insurance people. So this is somebody who typically is working or is the spouse or dependent of somebody who is employed who has private benefits. You may buy the personal benefits that you see advertised on TV, but for all arguments now, we're just talking about somebody who does have private insurance. Typically, these days, when you get to a more sophisticated diagnosis, there's a more sophisticated and more complex medication that will go with it. If you've been diagnosed, for example, with age-related macular degeneration, wet AMD, then there's a biologic that is being prescribed that must be injected by a retinal specialist or a general ophthalmologist, depending on which province in which you live. And these medicines are not without a pretty good price tag on them, and they're complicated to deal with, not just because of the price and the complexity of the molecules, but even the delivery system. So there's a whole system of specialty pharmacy and patient support programs and healthcare professionals that are all working together behind the scenes for you. When you've been diagnosed, you have a prescription, and your doctor says, well, we're going to start monthly injections. The goal is to eventually have those injections spread out further, and Keith will talk about how the system collapsed in COVID, and a lot of people had to go without injections. But in a perfect world, you would have monthly or bi-monthly, maybe even a little bit more individual treatment, but you would have it spread out, and you have to go to the healthcare professional to have the injections done. Whether it's the injections or glaucoma medicines, in the insurance world, typically you have to pay part of it yourself. So some systems, very few people now would have 100% coverage by their insurer. They might have 90% paid for by the insurance company, and you have to pay 10% out of pocket. Everybody has a little bit of skin in the game. That's how it's described in the business. And that's to make sure that everybody's honest and there's no abuse, and that it's affordable and there's no waste. Sometimes now, to keep the premiums for your private insurance the same, you may notice upon renewal that instead of a 10% copay, you're now having a 20% copay, or maybe even a 30% copay. And that copay becomes a little bit too expensive for an individual or a family to bear. So there is something called a patient support program. And if it's an expensive drug, please check, because I can almost guarantee you that somebody will help you pay that copay if it's not affordable from your own pocket or that of your family or the household in which you live in. So the patient support program is there not only just to help you with your copay, but also with the reimbursement criteria, because the more complicated the disease or the diagnosis, the more complicated the medicine, there's usually criteria that the patient and the physician have to make sure that those criteria are met before the insurance company or the government will agree to pay. And the logic behind that is that they don't want people racing to the most expensive and easiest medicine or the one that's the newest if there's something that's good and proven and reliable, maybe less expensive, that could be used first. So it's kind of, if you just put those common sense parameters around it, but you have to sort of go through the criteria, and has the patient tried product A, product B, product C, or does the patient meet this criteria in terms of the vision loss or the age or comorbidities, all the different things that the doctor and the healthcare professionals are all looking at. This requires a lot of paperwork. So again, We don't want the physicians taking a whole lot of time filling out papers, so that patient support program or the office managers, those people are all trying to help you as the patient or the caregiver or the family member so that you can focus on what you need to do, which is get the medicine, look after yourself, and not worry about money or paperwork or logistics of how a specialty medicine is going to be shipped across the country in cold storage, how's it going to get to the doctor's office before you do, all these sorts of things. So just know that there are a lot of people in the background, but you can also check in with those people to help. So as a patient or a family member or caregiver of somebody who has been prescribed a more expensive or more complicated medicine, do check to see if there is a patient support program to go with the medicine that will help you with some of these things. And also, not just the physician, but the pharmacist that you use or your insurance company will help. If you come up against barriers, you can also go to the Human Resources Department if you are a patient who has benefits, or your spouse has benefits, or your parents have benefits. And a lot of people don't know that, and John will probably talk about self-advocacy, but you can go right to the source of who's paying for the benefits to help figure out the problems, because sometimes there's new people on every job and things just fall through the cracks. And what I would want you to know is don't ever take no for an answer the first time. Dig a little bit deeper, and you have resources such as the Canadian Council of the Blind, Fighting Blindness Canada, the websites of all the pharmaceutical companies, the pharmacy that you would be using. There are a lot of people who want to make sure that that script becomes medicine for you. The other part that after, like putting insurance aside, if your medicine is going to be paid for by the government, then you don't have to worry about things like copay, but the criteria that you have to meet sometimes will be quite a bit stricter over on the government side than on the insurance side. And that's typically because the insurance companies are covering younger people who the reason they even buy insurance for the benefits is to make sure that people can quickly get back to work and remain productive. The government is looking at it through the lens of public health and public safety, and making sure that the budget is spread out the most efficiently for the most people. But in the government system, again, there are always criteria, and the criteria are publicly available, and they're different by each province. And it's very important to only look at what's happening in your own province, because it can get very complicated if you compare yourself to your friend that you know in another place, because it's really not equal oranges and oranges and apples and apples. So, but again, within the government system, your healthcare professional, your pharmacist, the patient support program, and the pharmaceutical company itself, all those people have, or all those groups have professionals that will try to help to make sure that you don't fall through the cracks if you come up to a barrier. Finally, if that prescription has gone through the system and you know that it is going to be paid for, or that you can afford all the different ways to have it paid for, and you're ready to go, the last thing you need to do is make sure that there's informed consent. And this is particularly important in the vision community as you go further west. There are some very expensive medications that governments have been trying to play with budgets and doses and different ways to make their budgets be stretched. And sometimes patients have been signing documents and taking on prescriptions of things that they aren't necessarily sure that that's what they agreed to or that their doctor prescribed. And to Chad's point, and it will be spoken of across the panel, just keep asking a lot of questions and make sure that you are getting what was prescribed. And if you have any questions, keep going back through the system, as I suggested. But the patient support program and the pharmacist are auxiliary parts of the system that the physician can download You can get information from them because the physicians are sometimes too busy or don't even know the details of the system. So use these other parts of the system to help you so that if you ever get a no, you can keep pushing to get it to a yes. Now I'll pass it on to Keith.
Well, thank you very much, Sarah. This is on now, okay. Well, Sarah's mentioned how you can acquire a medication. The medication has been recommended for you. Chad talked about how you first go to your optometrist and they will then diagnose the condition, pass you on to an ophthalmologist who writes a script, which then goes to Sarah, or Sarah's chain that you've just talked about, and that's how you get the medication. I'm going to talk about the importance of compliance with that medication. And I'm going to talk about the whole issue of side effects of that medication. I like Mike's introduction when he talked about the fact that knowledge leads to better health. And I think that the whole issue of knowledge, of gaining knowledge, is a dual responsibility. It's not necessarily the responsibility of the doctor only. The doctor has a responsibility to give you that medication, to tell you everything about it, but it's also your responsibility as a patient to get as much information as you possibly can. So I'm going to talk about the doctor's responsibility and the patient's responsibility. Okay, so first of all, it's the doctor's the doctor's responsibility to explain to you what condition you have and what your prognosis might be, how your vision might progress in the immediate and distant future. Your doctor needs to explain to you why it's important that you comply with taking your medications and why you need to keep the visits that he or she has planned for you. And Chuck has talked about the need to follow to make sure that you adhere to the follow-up visit schedule that your doctor gives you. But more importantly, I think, is your responsibility as a patient. Your responsibility is get your questions answered. And Sarah I like the way you ended that, Sarah, about talking about, it's your responsibility to find out yes or no, but it's really your responsibility to get your questions answered and beat down that door if you have to get the answers. If you feel you haven't got all the information, there are many credible websites where you can get the information you need. Twitter is not a credible medical source. There are websites such as the National Eye Institute in the United States, a number of the major medical schools such as Harvard and the Cleveland Eye Clinic. But you can get that sort of information online, and then to filter it and to get some meaning put behind it, I suggest that you need to contact your optometrist, your pharmacist, your family doctor. They're all there to help you, and they shouldn't brush you off. You have the right to get that information. So let's move on to the whole issue of compliance and why it's so important that you take your medications as recommended. If you're taking eye drops daily, it's important that you don't miss a day. Don't say, oh, well, gee, I'm too tired tonight, I'm not going to take it. And to give you an example of why that's so important, I'm going to talk about glaucoma. Now, glaucoma is an asymptomatic disease. That means that most of the time you don't know that you have the condition, and you can lose vision without being aware that you're losing that vision. Various studies have shown that about half the population of people that have glaucoma aren't aware that they have it when they're first diagnosed. Now, the way that glaucoma is treated is mostly with the usage of eye drops that control the pressure within your eye. So to control that pressure properly, you need to put those drops in every day. Studies have shown that the pressure in the eye can spike, can go up, if the eye drops aren't taken even for a day. There was a major study done a few years ago called the Canadian Glaucoma Trial that showed that for every 1 millimeter of mercury pressure increase, the risk of the progression of the disease increases by a staggering 20%. So what does that mean? That means if, let's say your pressure is under control at a pressure of 20 millimeters, and you don't take your drops for a day and it goes up to 21. That means that your risk of developing vision loss increases by 20%. So I'll say that again. If you go up a little bit by not taking your drops for a day, you increase the risk by about 20%. So it's really essential that you adhere to taking that medication every day. Now, treatment of glaucoma with eye drops isn't necessarily that easy. It usually starts with a single medication, and then you're monitored by your eye doctor, either your optometrist or your ophthalmologist. And if your pressure goes up, they might add a second or a third medication in order to control that pressure. In order to do that, as Chad has already indicated, you need to see your doctor regularly, probably every 6 months, but it may be more frequent depending on your condition and depending on the stage of your glaucoma. If you miss any of your planned visits, you run the risk that your pressure may have increased, because you wouldn't know if the pressure had increased, and you may be losing vision unnecessarily. So keeping that regular appointment is essential. Now, I'm just going to talk a little bit about the complexity of taking glaucoma medication. If you start with a single dose, most of the time doctors start with a medication called a prostaglandin analog. The prostaglandin analogs are taken once a day at bedtime. So that's reasonably easy to adhere to. But now your pressure goes up a bit and your doctors add another medication. Well, there's a whole choice of other medications, and I'm going to just run through them. You don't need to remember them. You don't even need to know what they are. But beta blockers, which often is the next stage, it's often a drug that is added to the first one, are taken once or twice a day. So now you're taking a drug once a day and another one twice a day. So you now got to remember, hey, I've got to take 2 drops at bedtime and 1 in the middle of the day. So this is getting complicated. There's another drug called brimonidine that's taken 2 to 3 times a day. Another group of drugs called topical carbonic anhydrase inhibitors are taken 2 to 3 times a day as well. And finally, there's a group of combination medications that are taken 2 a day. So this gets complicated, and I suggest that it's really important that you lay out a schedule for yourself. If it needs an alarm clock to go off every 12 hours or every 8 hours, set it, or use your iPhone to set up some sort of a reminder schedule. One other aspect of compliance is getting that darn drop into your eye. Drops don't work if they're dribbling down your cheeks. So it's really important to get it into your eye. When you first start putting an eye drop in the eye, get a family member to help you to pull down your lid and put it into your eye. But after that, get used to it so that you can do it yourself. There are great descriptions online that you can find of how to do this best, and I think it's really important that you do it, because your family member is not always going to be around at the time you want it. I'm not saying permanently. Okay, I wanted to talk about so that's glaucoma, and that's just an example. All of those issues apply to other medications as well. And Sarah's already talked about anti-VEGF injections. It's essential that the anti-VEGF injections, the schedule for them not be missed either. When you first started, the doctors usually give you an injection once a month for 3 months and then may change it a bit after that. Different doctors have different ways of doing this. But those first 3 months are essential, and so are all the others. So if they say, I'll do it once a month for 3 and then come back in 2 months, come back in 2 months. Don't say, oh, well, last month we didn't do it, I'll go 3 months. It's really essential that you keep to that schedule to maintain the effectiveness of the medication. So that leads into the whole issue of the pandemic, which Sarah's already talked about. We did some research last year in order to look at the impact that the pandemic had had on various treatments. And we found that, first of all, pandemic had made compliance with regular eye exams and medications much more difficult, as we might all expect. But we got some real numbers here. Across Canada, there were 3 million fewer visits to optometrists in 2020 compared to 2019. So that's a huge number. It means a lot of people are not going to see their optometrist. It means they're not getting diagnosed early, and we know that early diagnosis leads to early treatment, which leads to prevention of vision loss. Early diagnosis, early treatment, prevention of vision loss. It's essential to get to your optometrist on a regular basis. The second thing we found is that there were 70,000 fewer injections into the eye for the treatment of macular degeneration or diabetic retinopathy in 2020 compared to 2019. That means a lot of these people are not doing were not doing those monthly injections that I just talked about and that Sarah mentioned. So we found that there were a lot of people had lost vision unnecessarily, and it's essential now to get back to your normal routine. Make those appointments with your optometrist for the regular eye exams. Make the appointments with your ophthalmologist for those injections that you need. And if you hadn't had cataract surgery, we showed that across Canada there were 143,000 cataract surgeries, fewer cataract surgeries done in 2020 compared to 2019. So people weren't having the medications, they weren't having the surgery, and if you fall into that category, get to your doctor ASAP. So moving on, I'd like to talk a little about the side effects of medications. Most medications produce some side effects in some patients. This isn't anything to be particularly worried about, but I think it's important that when your doctor prescribes a medication for you, that you understand what the side effects are. Ask the doctor if there are side effects, and if you're taking another medication, ask the doctor if there's a possibility that the medication you're taking for arthritis might cross-react with your medication for your eye disease. I'm not saying that they do, but it's important to ask that question in order to understand it. I'll give you an example of some of the side effects that medications have in the eye may exhibit themselves systemically within your system. So the one example I like to look at is if one is taking a beta blocker for glaucoma, that's one category of drugs. Beta blockers can slow down the heart rate. So if you're taking, you don't think, hey, if I put a drop in my eye, it could slow down my heart rate, but it can. And very often when people first start taking a beta blocker, they find that they get quite tired, they can't make it up the stairs, they can't play tennis as often as they could. So these are things that one needs to understand. It's not a major issue. People can usually get over it, but it's important to understand that. Knowledge leads to better health. A wise man by the name of Balajan once said that. If your ophthalmologist doesn't take the time to tell you about possible side effects of medications, it's important that you ask your optometrist, ask your family doctor, ask your pharmacist, and most importantly, read the patient insert that comes with all medications. They're written there specifically for patients. Obviously, the patient insert isn't going to be accessible, but there are accessible versions online, and if you can't access them, ask a family member to read it or read it to you. So moving on from the side effects related to drugs, I'd just like to talk about one side effect related to losing vision, and that's a condition called Charles-Bonnet syndrome. Charles-Bonnet syndrome is a condition where people who are losing vision develop visual hallucinations. That means that they see things that aren't there. They're not usually very frightening, and they don't usually last very long. But if you don't know about it, it's quite disturbing. Just to give you an indication of the frequency of this, we did some research when I was at CNIB about 7 or 8 years ago, and we asked about 2,500 people who were coming into CNIB who were experiencing vision loss for the first time, whether they had experienced visual hallucinations. And we showed that about 1 in 5 people, that's quite a large number, out of 2,500, that's quite a few. I can't do the math right now, but so 1 in 5 people experience visual hallucinations, and this is irrespective of the cause of the vision loss. 1 in 5 people with glaucoma, 1 in 5 people with macular degeneration, 1 in 5 with diabetic retinopathy, we're experiencing hallucinations. So irrespective of the cause of your vision loss, you've got about 1 chance in 5 that you might experience some hallucinations. Most people get over it. It's not a big deal. But the hallucinations can run the gamut from patterns to little people sitting on the end of your bed every night when you go to bed. But they don't stay there for long. They go home. Anyway, we did a subsequent study where we asked people we took a small sample and asked people what some of their experiences had been about telling folks that they had hallucinations and whether their doctors had told them about it. And we found that a large number of this population said they had not been told by their eye doctor about the possibility of developing hallucinations. A subsequent study we did was to try and understand whether general practitioners, family physicians, knew anything about visual hallucinations, and we found that the level of knowledge was very, very low. We did a survey of family physicians and found it was very low. And some anecdotes started popping up where people said that they had referred people with hallucinations to psychiatric wards in hospitals, which the only thing wrong with them was that they had glaucoma. So it's really important that we understand this before one goes off on a tangent. And finally, we asked retina specialists whether they discussed the possibility of a patient developing Charles-Bonnet syndrome when they speak to their patients who have severe vision loss, and 56% of respondents to that question said that they did not. So that's more than half of the retina specialists that are diagnosing patients with severe vision loss and not telling them that Charles-Bonnet syndrome is a possibility. It's important that one understand this. There's a lot of information online about Charles-Bonnet syndrome, and there are pamphlets given out by a number of health professionals. And if you contact me any time of the day or night, I will answer anything you want to know about Charles-Bonnet. So, in conclusion, ophthalmologists often do not have the time to give you a full explanation about everything. Ophthalmologists and optometrists, you need to do your own research, and you need to keep on asking questions. Beat down the door, get the answers. And with that, I will pass it over to my friend John. Sorry.
Jim's in the CCB.
Right, too many. All right. Well, thank you very much. I want to say it's, for a guy whose last name is Adams, it's nice to be last on the list. All right. Usually, hey, I remember being first in line in elementary school for that polio shot. So, all right. It's been like that for most of my life. So I want to say that I do a number of different things, and one of those other things is I'm also the volunteer board chair of an umbrella organization of 29 different patient organizations, something called the Best Medicines Coalition. I think the name tells you what it's all about for patients, and it's a great pleasure. Jim Tokus does a great job of providing national leadership for the Canadian Council of the Blind, and he has been for many years the representative of your community on the Best Medicines Coalition. It's delightful to see Jim here with us today. My theme is advocacy and self-advocacy, and I'm going to start with an example of self-advocacy. It's okay to steal a good idea from anybody, and that's why I'm glad that my friend Mike has stolen the idea from the Canadian PKU organization that knowledge leads to better health as the theme today. It's okay. I steal good ideas from any source. Our theme at Best Medicines Coalition and elsewhere is nothing about us without us. We don't want to just be at the table. We want to be there when the guest list is drawn up and when the menu is designed. Because if you're not there at the table and in the planning for the table, you're on the menu. And others might be not be able to avoid the temptation to take advantage of you. It's important to be educated. We all need buddies in this life. So it's important to consider having a buddy in your journey about your health care. It is your life, it's your health, it's your vision, and peer support is incredibly important, and peer education. So those are just a few, whether or not you can drive a car, whether or not you you can drive a bicycle or a wheelchair, you need to be the driver of your health and your well-being and your health care. Don't be a passenger, be the driver. It's your life. So those are my, I want to, Sarah made a key point. If it's a complicated and or expensive intervention, a drug or whatever, there almost certainly will be a patient support program. Use it. They're great. You could spend your whole life trying to understand how the government drug reimbursement plans and device reimbursement plans and how the private insurance reimbursement plans work. You don't need to become an expert. You need to rely upon the patient support programs when they're available in your space to help meet your need. That's why I say in the rare disease community of PKU, we have a frontline therapy, which is a nutraceutical. The problem with PKU is protein in food. So we're going to solve the problem in PKU, you're going to stop eating protein. Oh, that's a problem. That's not compatible with life. So that's a problem. So we have synthetic protein, but now we have, because of investors and scientists, we have emerging drug therapies, and it's a rare disease. On a per patient basis, they're not cheap. And so I have a son with PKU, and turns out he was in a clinical trial for the first drug therapy. Drug doesn't work for everybody. With his particular condition, we're very fortunate. He's in the top 1% of the world in responding to that particular molecule. So, and the problem with PKU, it's not life-threatening, it's only brain-threatening. It's a cause of old language, mental retardation, new language, intellectual disability. And that a baby born who has PKU that is not diagnosed and not put on immediate therapy will lose 1 point of IQ a week. And so by the time of their first birthday, and irreversibly, all right? So they will lose 40 or 50 points of IQ. That's why we have a program called screening of newborns, so that we do a blood test on the second day of life. A nurse comes in and pricks the heel, and 14,999 times, that blood test result is all clear. But one time, we test 15,000 to find the one with that, so that we can prevent mental retardation in those patients. Now, my son, we need better therapies in my particular space. I'm sure you need them in your spaces. And we're making progress. So the good news, it was absolutely, taking that drug at the age of 20 absolutely changed my son's life. And so struggling in university became straight A's. And the brain fog was gone. All right, and he has a job here in the city of Toronto, and you might meet him if you need real serious help, because he drives a fire truck here. He's the first responder, all right? And you don't want the guy driving that big rig down the busy streets at speed, even with lights and sirens running. You don't want him having an episode of brain fog. You really don't, all right? So, all right, and he's living the dream. His granddad, my dad, was a firefighter. So, all right, that skipped a generation. I only did the budget for the fire department when I was on city council. So, okay, so that's in the, you can't understand me as a patient advocate without knowing three things about me. Affected me as an experience as a child, and as a parent, and I've told you a little bit about that, and as a spouse. When I was 9 years old, my mother was going to die of a serious heart problem, and so the doctor said, well, there's a Hail Mary we might pull off, highly risky. So my mother became the first person in Canada to have open heart surgery and come out of the operating room alive. When she came out of that room alive, she reduced the fatality rate of that experimental procedure to only 75%. These were really sick people. And she had her chest cracked open 3 times over the next 15 years. I've yet to find another person who's had their chest cracked open 3 times. So she died when I was 24 instead of dying when I was 9. But so we've been there, the Adams family, we've been there at the cutting edge, literally. And today, it's a dime a dozen almost for that procedure. And they can do it with almost non-invasively now in some cases. As a dad, we got the phone call because of the newborn screening program saying, you have an appointment tomorrow at the hospital for sick kids. Bring your baby, bring your wife, be prepared to spend the day. Well, this was in the deep, dark old ages before the internet. But we had the pre-internet called the Encyclopedia Britannica, and we got the kids to sleep that night, and we dived into the encyclopedia, and we found phenylketonuria, PKU. We started reading, and then the daggers came right off the page. Profound, irreversible mental retardation. Right to your heart. And we lost it that night, but we've had a really good outcome. And I think of, and maybe I'm using the term incorrectly, but I think of those frequent and regular checkups of vision at the optometrist is a form of screening. It's population screening. It's not the newborns, and there's different timings for the screening at different ages. I mean, my vision loss, I used to wear knee glasses for reading and for vision, and then I got cataracts. And then I got the lenses replaced. And so I've got one eye for vision and one eye for reading. All right, so, and I realized when we were prepping for this panel, oh my God, I haven't seen my optometrist before the pandemic. So I've made the booking for next week. So thank you, Dad. And if you haven't seen your professional vision care person for a while, that's on you. You got to do something about that. You got to be a self-advocate. All right, so that's, I think, and the other thing, of course, I have a little bit of dry macular degeneration, so we do want to keep an eye on things, literally. The other thing is I want to say to the organizations who are represented here, as well as the individuals, that the province of Quebec for all patients has a program that is unique in all of Canada. It's called the exceptional patient. And when there's a problem, when the drug is not on the list of approved products or whatever, a doctor can make an application to an independent scientific committee to get it paid for by the government. Patient exceptionnel. And as we're thinking about reforming access to drugs and other things to improve healthcare for Canadians, I think every Canadian needs to have the option of being an exceptional patient. Thanks very much.
Thank you, John. Thank you, panel. Let's give this panel a big round of applause. Now, what we're going to do before we go to questions is we're going to give each panelist a couple minutes to speak to something that they may have heard from the other panelists that they would like to bring up that may add to part of the conversation. So let's start with the A end.
Actually, I have a question for Chad, and this may be old news, but for some of us, and it's just, I think it's just Ontario, but I remember around the time the pandemic started, that there was a little bit of a fee problem between the optometrists in Ontario and the province of Ontario. And people were having either to do without or having to pay in some cases. Has that been sorted out?
It's a very good question, actually. Yeah, it's still in the process of being sorted out. So negotiations are still underway. There's been a pause to some degree. I work for the regulatory authority that oversees the optometrists in Ontario instead of the association that advocates on behalf of optometrists. So myself, my organization are at arm's length to some degree. But for a while there, it was the case in Ontario that optometrists were no longer providing eye exams to those with public health insurance in Ontario. So that's individuals who are, I believe, 19 and under or 65 and older. And the great news there is that is no longer the case. So optometrists are now providing those really essential eye exams. That's something that I tried to do is provide a sense of why regular eye exams are so important, whether you're symptomatic or asymptomatic. So yeah, it's ongoing, and we're keeping our fingers crossed for a resolution in the near future.
Thanks, Chad.
Yep.
Good stick handling.
Oh, thanks.
We're all hoping it ends soon. Keith?
I have a couple of questions I'd like to throw at my colleagues. I'd like to start with A. Okay, so you've gone to your doctor, and your doctor gives you a diagnosis that you either find too dire or you don't agree with, and you want to question it. How do you proceed? The doc probably doesn't want to hear anything more from you, or just what would you do? How do you beat down that door to get an answer that's satisfactory to you? And I think we all have examples in our lives where we've beaten down that door and found that we actually were able to save our relatives from getting worse in whatever condition they had.
It is important to be proactive, but I have to start to respond to your question by asking you a question. Did you have a buddy with you at that medical appointment? All right? Because I think it's, if you think you're going into a meeting with your healthcare consultant, all right, that you're paying for through your taxes, your medical doctor, that's your healthcare consultant that you're paying for indirectly through your taxes. And particularly if you think there's going to be the possibility of new information coming out, and it might not be good news, all right? You might have a traumatic experience from that, and you might stop learning in that moment, because that's what happened to me and my wife when we got the phone call, bring your baby to Sick Kids tomorrow, be ready to spend the day. What? If you're taken by surprise, if you're not ready for it, your learning tools are going to shut down temporarily. So it's really important that you consider having a buddy with you for any significant medical encounters. All right, as a peer support advocate, and our healthcare system is not simple to navigate. Number one, you have a right. You have a legally enforceable right to get a second opinion. All right, and that's a showstopper. All right, if you're hitting a barrier. If you want to say, I need some more information, can I get, you actually have to say, please, what's the procedure for me to follow to get a second official opinion? All right, that's your power to use it. And I've used it in the case of my late wife, because I wanted a second opinion of some very sophisticated data. And, well, I was being given the runaround and the excuses, and I finally said, why do you want this, access to this raw data from this scan? I said, because I want to get a second opinion. Oh shit, yeah, right. All right, so those were my, at least, starting comments for people to consider. All right.
Thanks, very helpful. I've got another question for Sarah. Okay. You've given us a really good idea of how to deal with the issue of funding of drugs. What about devices? You got any thoughts on intraocular lenses or other devices that one's having implanted during surgery that one is asked to pay for? How does one proceed down that avenue?
I'd love to give you something insightful, but I don't have as much expertise on that, so I don't want to say anything that might not be correct, to be truthful. It's probably the same process, but I don't know. So I'm sorry, I don't know how you get the different lenses paid for. Yeah, I don't want to give any bad information. But my thing that I wanted to my comment after listening to everybody was similar to Mr. Adams, John, is that take notes, take somebody with you to your appointments, and try to consolidate your questions so that, again, the healthcare professionals we've seen in the pandemic, over and over and over, they're stretched beyond their capacity in many cases, and some of them are not even busy, depending on where they work. But typically, you don't get a lot of time with the healthcare professional. So take a friend, take a family member or caregiver, but take notes. Get your questions ready and prioritize your questions. And if you can't get them all answered the first time, there are other places. So Canadian Council of the Blind is a member of the Best Medicines Coalition. And the Best Medicines Coalition is a group, they advocate for all patients across the country in every disease state. And they are experts in policy matters and interprovincial matters and pharmaceutical companies, pharmacy, politics. They are a group of, between them, experts at everything. So if you don't find the answers that you need, you can go through different health charities or go to Best Medicines Coalition. There is so much information out there, but it's overwhelming. And oftentimes, by default, we don't have the energy or the time or the interest to do that kind of research for ourselves. That's where your buddy can come in, because for sure your loved one will want to be advocating, as John has described how he did it for his son. Don't take it all on yourself, but try to be prepared for your questions that you have for the healthcare professionals along the way, because honestly, there is an abundance of information and everybody is trying to make it simpler and easier for you. But if you don't enter the system at the right point, it's like a clock. If the answer you need is over at number 9 and you've entered at number 2, it's really difficult to get all the way over to where your question can be answered. But if you use the different people in the system, honestly, everybody is trying to make it easier for you. So please ask questions.
Yeah. I guess what I would like to say is that I've been thinking a lot about informed consent over the last couple of days in preparation for this panel. And one thing that occurred to me is that one way of thinking about informed consent is imagining it as a kind of subsection of a larger category, which we could possibly call patient communication. And over the course of this panel so far, I think that that's perhaps been a theme, is this notion of patient communication and how important that is. And I really like what Keith said, that the communication that occurs between an individual with lived experience of vision loss and blindness and the vision care provider is a two-way street. So there's a responsibility for the provider to provide good information, and there's a responsibility for the patient to learn as much as possible and ask the right questions. It's definitely the case, and I know this from speaking to patients over the last several years, that only so much communication can happen in that one meeting with your ophthalmologist or your optometrist. There's only so much information that can be moved in one direction or the other. And because of this, there have been several programs in Canada and elsewhere that have been pilot tested over the last 5-10 years that have involved individuals called patient navigators. And I think that this is a really innovative idea and potentially has a lot of value. So the core concept is that once you step away from that initial conversation, perhaps the conversation where you're diagnosed with a rare eye disease, to use an example, I mean, you're overwhelmed, right? I mean, that's an overwhelming moment in your life. You're told, for example, in the case of something like retinitis pigmentosa, that the cells in your eyes called photoreceptors that are responsible for absorbing light and producing vision are slowly dying away. And this is a kind of linear path towards vision loss. It's irreversible in many cases, in most cases. So how do you take in any information at that moment in time? You can't really. So the idea is that you'd be able to step away from that conversation, absorb as much as possible, and then engage in another conversation with a patient navigator who would kind of help you understand the diagnosis and then help you navigate through the complex vision care system that Sarah was describing. I think Sarah really hit on that, the complexity of the system, and Keith touched on it as well. So that's just something that comes to mind, is that patient navigators are something that we can think about that could be a really valuable resource and tool within the vision care system. And when I was working at Fighting Blindness Canada, I'm at the College of Optometrists now, but I used to work at Fighting Blindness Canada, one of the main blindness organizations in Canada, and we developed an online tool called Vision Care Pathways. And the idea is that would function like a patient navigator, but it would just be an online resource that you could take your own time with and read over. So that's just something I'd like to throw out there, is that Vision Care Pathways on the Foundation Fighting Blindness website is a useful resource if you're trying to find exactly where you need to be in the vision care continuum. And then just very quickly, the last thing I would want to say is I'm struck by what John was talking about, the exceptional patient program, because it occurs to me that it seems like absolutely essential that we have that in place in Canada. It was also the case when I was at Fighting Blindness Canada that we were doing some advocacy for a rare disease drug called Luxturna, which can really help young kids with a form of retinitis pigmentosa called Leber congenital amaurosis. And it was proven that that drug, which is still, I believe, the most expensive drug in the United States, $1 million for a one-time treatment, it was shown that that drug could halt vision loss and even restore some sight. So it's not a cure for this disease, but in some ways it's a miracle treatment. And what we found when we were doing our research and advocacy is that in Quebec, they had approved a young boy to be a part of this exceptional patient program. He had received Luxturna and had incredible results. So just when thinking about the way that we can develop innovative policy solutions, that really stuck with me, the idea that maybe we can find some way to take the exceptional patient program and apply it broadly across Canada. I think that could be incredible.
Thanks. Thanks, Chad. And speaking about Luxturna, one of the situations, am I right? It's like maybe 150 people in Canada. Yeah, it's a very small number of people. It's maybe 150 could be here with it. They've identified maybe 45 across the country, but you know, you have to look at the people have to look at it from a moral point of view, the value of somebody living with sight, or the value against what happens if you don't take care of it. So there's complications that come into play, and you know that's something right now. That debate is going on across the country in a number of provinces, and saying you have to look at it, you have to work with it, and it's a moral obligation, and that's the approach that's being taken. Fighting Blindness Canada, Doug Earl, President of Fighting Blindness Canada, Jim Tokas, the Canadian Council of the Blind, and I think CNIB, everybody is working together to get this drug approved. And yeah, we recognize it's $1 million, but you know, what's a heart transplant? What's the complications of a life treatment with a heart transplant? You don't want to go against what somebody else is, but the point is, where do you draw the line? And you know, the important thing is that these people deserve their sight. One final thing, Mr. Adams.
I can't resist the temptation to leap in on something that it's not an inexpensive drug, but it's no longer the most expensive drug on the marketplace. There's another one for rare life-threatening conditions, spinal muscular atrophy, which is neurodegenerative and lethal. And there were treatment drugs at $500,000 a year, and now there's a gene therapy by a little company called Novartis. All right. And the list price is $2.1 million, but it's a one-time therapy, and we have to get beyond the sticker price shock part of the conversation in a number of ways, because I know that I expect my governments, and I used to be part of one, I used to be the budget chief for the city of Toronto, I expect my governments to do a really good job of bargaining with suppliers for bulk purchases and value propositions. And it took them a while, but they're now well organized in the drug space to do that collectively by all the governments of Canada. I expect them to do a good job of making those deals. But the other thing is, we need to think about, we're now in the time of cell and gene therapies, where it's not just you take a pill every day, but you can have an intervention, a drug, a cell or gene therapy, and you're good for 5 years. You may be good for 50 years. And that's like making a capital investment in the well-being of a human being. Like, we don't pay for our fire trucks and our schools and our roads and our subways out of operating funds every year. Not too many people buy a house all cash in 1 year. Most of us are making an investment, and we pay for it with a mortgage over time. We can do that for things that have long-lasting benefits to the health of human beings. We can pay for it over time. We don't have to pay for it all in 1 year out of the operating budget. And so we have to help provinces, premiers, treasurers, and health ministers and deputy ministers understand about bringing the notion of capital investments in human health. That's my policy editorial comment for the moment.
Final addition before we go to questions. You look at a pharmaceutical company that goes out and spends $1.75 billion investigating a drug on research and finds there's only 45 people in the country or 100 people in the country. How do you qualify to your management and to your team that you just spent $1.7 million for something that's not going to return anything more than, you know, $45 million? And so those are questions that you've got advocates, the 29 people that John was talking about in Best Medicines, and you've got advocates, and those are the arguments, and those are the debates, and those are the research letters that are or the letters that of support for these drugs that you get from the Canadian Council of the Blind and Fighting Blindness Canada and the optometrists and the ophthalmologists, that we go and that they asking people to continue making these drugs, because in our view, and to quote Louise Gillis, we want to have best medicines so the people that are living the experience of blindness have an opportunity for the best quality of life possible. And with that, we'll go to questions.
I just,
Oh, yeah, okay.
I want to have the last word. Which sort of leads on from what John and you were both saying. I think what governments need to understand is that drugs are not necessarily a budget issue, that there's another aspect of that, whatever you call it, the ledger, and that is the cost of vision loss or the cost of an eye of whatever disease it is. It may cost you $1 million for your treatment, but the cost over a lifetime of vision loss is huge, and I think that needs to be put into the equation.
With that, I'd like to go to questions. So first, let's go to the audience. Is there people here or anybody who has a question they would like to ask?
Thank you.
Yes, sir. Would you give your name? And
my
then
name
stand
is
up,
Milton Charlton. This is related to the two A's and the intersection of patient advocacy and the funding of optometry in Ontario. So I was aware of the problem with the funding of optometrists, and this concerned me because it seems there are very few optometrists who have a special interest in low vision people. I've been to the two of them. They have a limited number of devices and so on, but I was very concerned about this funding of optometry because I didn't want either of these people not being able to offer this service, which has become quite essential. Now, patient advocacy, something all of us can do is write your MPP. I did that to my MPP, and lo and behold, she was actually on a committee that had something to do with these decisions. Now, I got a very nice letter back, not promising to do anything, but they paid some kind of attention to this. So I'm just advocating that as a form of advocating for yourself, write your MPP, tell them to get on it, get this funding situation settled, because low vision optometrists have to get a bunch of extra stuff. They want to get OCTs. They want to get some devices to offer to people. Well, they're really expensive. The other thing you can lobby about is the ADP, which seems mired in the 80s somehow. The ADP will not fund electronic devices, wearables, goggles. Now, Canada has an excellent device called eSight. This is for people with limited vision, developed here. And what else? Manufactured here. Do you know of anything else that's manufactured in Ontario that's a high-tech device? I don't. Well, cars, okay. They're manufactured here, but they're not designed here. Anyway, that's not on ADP. In fact, none of the wearable electronic stuff is on ADP. Now, electronic stuff there's some problems. There's servicing, there's all kinds of things. Maybe they don't last as long as a 4-inch magnifying glass. Okay, yeah, but I don't see why they're not getting funded. I was just saying, if you want to have this happening, again, write your MPP about ADP, and I'm really happy that CCB and CNIB have been pushing this to kind of stick it into the ADP to get modernized. I don't think there was a question there, but sorry.
Thanks for your non-question, but I will give you something I was going to save to the end, but I will say it now, is that for the last 20 months, the Canadian Council of the Blind, along with AEBC Canada, along with the Canadian National Institute for the Blind, OCAD University, Balance for Blind Adults, have been working with, we did a study on the ADP program. We presented it to the provincial government in January and worked with the provincial government January, February, March, into April. And on the 21st of April, I received a letter from Patrick Discernay, who is the Deputy Minister over the ADP program. He also runs OHIP in the hospitals. And we have a letter and we have a commitment that has been signed by Minister Elliott and put in her portfolio to go to the next minister. And that guarantees that commencing in July, there will be a group of people representing the vision loss community that will be working with the government of Ontario, with the ADP people and the people in the government, based on the recommendations that were made, and to come to an understanding that the present program, they admit, does not serve well people with vision loss, and we have a commitment from them that we will work together to solve the problem. And it not only goes with what you're talking about, glasses, but it also goes about smartphones, which are not also on the list for things. And yet 76% of the people by our study, 76 of the people living with vision loss in the province of Ontario rely on a smartphone to go from for GPS, for getting around, for any number of apps. And so what we've told them that the reasoning behind not doing it was because, gee, we don't want, if somebody's blind and they want to lend it to somebody, we don't think that's right. And what we told them very frankly that, you know, my grandkids come over every morning before they go to school and spend 45 minutes, and then my wife takes them to school, and first thing they grab are the 2 iPads. And I asked the person right to his face, are you telling me you don't let somebody use your phone? You don't let a kid use your iPad? And they couldn't answer. So the point is, we actually have, for the first time in 5 years, and the first time in 10 years going back, but in 2 different categories, have got the province of Ontario. Now the problem is the province of Ontario probably has the best ADP program in the country. And the problem doesn't begin and end in Ontario. The problem begins and ends with getting the rest of the country to get on board with ADP programs for their constituents and for their members or their citizens in the other provinces. So it's a big role, but we have made a major step. And I would recommend, if you go to the Canadian Council of the Blind's website, www.ccb National, you go to the website for the for the CCB, you will find an opportunity to see the videos from last week's summit and from last week's gala dinner that were both held in Ottawa on the 16th and 17th. Both of those videos are available online. And if you go to the gala, about halfway through the presentations and the speakers, Uda Trevianis from OCAD University, on behalf of the working group and on behalf of the CCB, makes the announcement and goes into detail of what it means. So I would, if you want to find out about what's happening with the ADP program commencing in July, that's what you can you go and do. And I agree with you. There needs to be a broad expanse in what's available on it, and they are working in the dark ages right now. So with that, I need to go to questions. So at the back, there was a question from a gentleman at the back. Oh, no.
Okay. Hi, everybody. Okay, it's Yin here, and I'm one of those people with RP that lost eyesight over the many years. So there's the recommendation to see your ophthalmologist or optometrist regularly. The last time I saw mine, I was so put off because he wanted money just to fill out a form for me to say that I'm blind. I stopped going to see him and anybody else for my eyes. So to the point of seeing your ophthalmologist or optometrist regularly, is there any point for a blind person? And also, what about this getting optometrist or ophthalmologist to fill out a form to say whatever your eye condition is, to show to a school if you want to, register for school, or if you want to apply for something, they want a medical evidence, and they charge us money. And people with disabilities are usually underemployed or unemployed. Is there any solution to this, or is this one of those patient advocacy things? Thanks.
I think there should be a solution to it. And Ian, am I right? There's access to that document that she's looking for through CNIB and different people about blindness and the ability, or is it strictly through an ophthalmologist?
No, it has to come from a medical professional.
Okay.
It's a medical professional certification of visual acuity that enables or certifies that you qualify for certain government assistance or programs.
Okay. I'll talk to you afterwards. Young lady, I'll talk to you afterwards. Gentleman at the back. Oh, shoot. Jeez. You shouldn't sit and slouch like that, Catherine. Catherine, you shouldn't slouch like that. I couldn't tell.
Sorry, I'll take this. I just had a quick question. Specifically for Chad. One of the things that I've experienced over my life is people who have decided that you don't really need to go to an optometrist till you're an adult. And I never understood that philosophy. I taught a martial art in which I told a parent that their child seemed to have a visual problem. You think that I had punched them in the gut. It was like, how dare you? It turned out the kid did need glasses, but it's just, they don't take their children to eye doctors. And to John's point, you have an advocate, you're a parent, and I don't understand why they're not dealing with it. I think a lot of the issues that we have as we grow could have been dealt with way earlier in your life if you had gone and taken care of it. Obviously, if you break your arm, you go to the doctor, but if you don't have visual problems or don't perceive visual problems, you don't go. And I never understood that, and I don't know what the answer is, so I'm hoping that you do.
Yeah, it's a really good comment, actually. And I think part of the problem there may be that, collectively at the social level, we often associate vision loss with aging. And there's a good reason for that, because, the eye, like any other part of your body, is a biological component, and it experiences the process of aging along with the rest of your body. So as you age, the likelihood of visual complications increases. And we know that one of the largest populations of individuals with lived experience of vision loss and blindness in Canada and other countries are individuals with age-related macular degeneration. So there's something to that. But if you remember when I was laying out the timetables from the Canadian Association of Optometrists, they recommend that individuals over the age of 65 get their eyes checked every year, but they also recommend that school-age children between 6 and 10 years of age also receive an annual examination. So that lines up with exactly what you're saying. And I think the idea there is that kids at that age, they may have things going on with their visual field, and they may not have the language to communicate what's actually happening. So you could have a child with a vision issue, something as severe as early onset glaucoma or an inherited retinal condition, and you just wouldn't know about it because they're not communicating to you that they're losing their peripheral vision or they're experiencing spotty vision or something along those lines. So do I have the answer to that? No, absolutely not. But I think that one step towards an appropriate answer would be that we all do some good advocacy to try to change this misconception that vision loss is just for those who are older. Vision loss is something that anyone can experience, and I think we need to pay special attention to young kids who are school-aged so that we can detect those complications early on and help these kids. So I think that there's a good public awareness campaign in there somewhere that I think would benefit this.
I would also
to understand how the dentist did it. How do people go and see their dentist at least once a year, and they don't go and have their eyes checked once a year? So your teeth are more important than your eyes.
But as far as children goes, at the last 2 or 3 months of the Wynne government, just before Premier Ford came into power, the Wynne government passed, indicated a program where every child at senior kindergarten level was going to get vision screening, and that's about 120,000 children. And this is at the end of, I think it was, when they come in, 2019, 2018. Anyways, the following fall, when the PCs came into power, they didn't act quick enough to properly fund it. So the next year was a very minimum number of people went through vision screening. The next year before it could start, we ran into COVID. And then the next year we had another COVID and nothing was done this year. So right now we've got 4 years, I think it'll be 4 years in September, where 120,000 senior kindergarten kids who are now in senior kindergarten grade 1, grade 2, and grade 3 have not had this vision screening, necessary for an eye exam, which brings me to what the stakeholders are looking at and what we're starting to discuss and what we'll be looking at is that the same way every kid goes into grade 1 with vaccinations, that no child can enter grade 1 without having an examination, which takes it off the government necessarily providing the vision screening, but puts it on the parents to get your child with an eye examination before. Because in the 7,000 different eye examinations we did with the mobile eye clinic in Ottawa, the statistics that we found about children in grade 1 and 2 and 3 and 4 that didn't realize that, 1.8% of them were found to be legally blind. So it's a problem. It's a problem, that we have to deal with. And then we have to advocate for a solution. Any other questions here?
Here's the microphone. I had a question. I have low vision in my left eye, but my eye doctors have been telling me, because I have cataract and the nerve behind my right eye is like completely damaged. And I said, is there a cure for that? And they're all like, there's nothing I can do for you. Is there a cure, or is it just like gone by?
This is the optic nerve behind your right eye?
Yeah, the optic nerve behind my right eye is like dead, they said, and they can't do anything, and because I also have cataract. Like,
Keith is the scientist on the panel, so.
Sorry, I'm not sure, frankly, that I or any of the panelists are really able to discuss your medical condition. I'm not a medical doctor. I know a lot about the conditions, but I really don't feel that I'm competent to be able to do that. So.
Yeah, I'm not either. The only thing that I would say is that I know the work is being done on optic nerve regeneration, but damage to the optic nerve is a difficult problem to deal with, which is why a lot of what we've been saying about glaucoma, which is a disease of the optic nerve, has been associated with early detection. Because with glaucoma, you want to get to the disease before the optic nerve is damaged. And once the optic nerve is damaged, then we're in the area of what some people are saying is irreversible vision loss.
Oh, so it's non-reversible.
I don't want to say that either, because I don't have a medical background. I'm not a medical professional.
I think what you should do is try to find a way, whether going back to your GP or going back, I would advocate for yourself in an insistent manner, and I would get somebody to give you, whether it's an ophthalmologist or your optometrist, and probably your ophthalmologist or whoever you saw, I would go back and try to really clarify what your situation is and what they can do about it. Whatever you've said today, like the panelist said, it's not something that we can get involved in, but we can tell you that you need to go and find out, and you need to go and advocate for yourself.
Yeah. Okay, thank you.
Next question is going to be at the from the people that are on virtually. Go ahead.
Oh, sorry. Okay. Well, I'm prepared to answer the next question. Next question is, can the panel comment and provide perspective on participating in a clinical trial? I ran clinical trials for many years for a pharmaceutical company. I've run clinical trials for CNIB. I have quite a bit of insight into that. It's a big question, so I'm not quite sure what this person means by it, but I think the issue to me is when you engage in a clinical trial, you want to have some understanding that when you participate in that study, that it is safe to do so. So I think it's safety that you're concerned about. So I think it's important to understand the whole process of getting a new medication approved. First of all, there's an amazing amount of toxicology that is done to look at a new drug before it even gets to humans. One looks at the pharmacology and toxicology of a new drug in at least 3 animal species to show that the drug is safe. Then they do a limited study in humans to look at the toxicology in humans. And eventually, when you're asked to participate in a study, it's been shown to be pretty safe. And what you're then looking at is a comparative study usually with, today, most comparative studies are done with what's called a positive control. So it's done comparing it with the existing medication. So nobody's going to leave you out in the cold most of the time. There are exceptions where they compare it with a placebo because there isn't a positive control. But most of the time, you're comparing it with a drug that is on the market to show that it's more effective than the drug that's currently on the market. There are studies that compare it with a placebo, which is a non-active drug, but that's really more the exception than the rule. So I think, again, to come back to your role as a patient, potentially participating in a clinical trial, it's important to understand what the medication is, what it does, how it's been tested, what the extent of the testing in animals has been, and what the extent of the testing in humans has been before you're asked to participate. approval of a new clinical study goes to the same rigor at Health Canada as the approval of the new drug. If a pharmaceutical company wants to have their new drug tested as a clinical trial, they have to make a full submission in the same way as you would a new drug to get the drug marketed. So I feel you can feel very comfortable that when you're asked to participate in a clinical trial, that it's a safe thing to do.
Keith, is there another question there? The next question?
I was finished, don't worry.
Yes. No, I just...
Yes, there is. Could Dr. Andrews repeat the guidelines by age for optometrist visits?
Yeah, sure, I can do that. So infants and toddlers should undergo their first eye exam between the age of 6 to 9 months. Preschool children are between the ages of 2 and 5, so that's at least once between the ages of 2 and 5. School-age children, age 6 to 10 years old, should receive an annual examination. And adults between 20 and 39 should be examined every 2 to 3 years. Adults between 40 and 64 should be examined every 2 years. And adults who are 65 and older should be examined annually.
There's one last question. I think I'll read the whole question. It says, patient navigators should be a profession. I had to hire one for doctors and my spouse to believe that my neuropathy was caused by glaucoma eye drops or any drops put into my eyes. It took 3 years to have surgery to help keep my pressure at a good level without drops. Is this a common problem with eye drops, including for dry eye? I can answer that. A lot of eye drops have a preservative in them. Not all eye drops. There are some that don't have a preservative. And it's been shown that these preservatives can cause the eye to become dry or can have an allergic reaction. So the first question one should ask if one has a medication that's causing irritation in the eye is it possible to have a similar medication that doesn't have a preservative? And very often there is one that doesn't have a preservative. So that's the first route I would go down. And beyond that, this person clearly went from having a medication to having surgery. You can have surgery for glaucoma to offset the need for eye drops. But that's fairly drastic, but that is a route that you can go down. But the first question is to ask, can you have an eye drop without a preservative?
Thank you. Is there any other questions in the auditorium?
Hello, this is Rosie Arcuri. I don't want to open a can of worms, but I do want to address this. So for the patient advocates, do they talk about things like balance or CNIB or mental health? Because what I've noticed is so many people are like, oh, there's no point in doing X. I will go blind. My life is over. Like, you know, they catastrophize everything. And because of that, they don't then get any medical assistance, let alone psychological and other assistance. So do the do the patient advocates do that? Thank you.
John, finish.
It's really tricky, I'm going to say. I mean, because a patient advocate, we tend to be informal. We're not a profession, all right? And we're certainly not healthcare professionals, and not in a position to be diagnosticians or treaters. But most of us have a sense. It's important to have peer support and say, hey, why don't we see about trying to meet up with somebody who is already had this and is living with it, has been living with it for a while, and get some perspective on this. So that's peer support can mean many, many things, but get to somebody who's further down the journey than you are in that moment. And I know the associations that are represented here today can be a source of referrals to those people, and in many cases they will do it as volunteers.
And just to build on that, today, the Expo, that's the whole point of the Expo. It's really great if you get to the point where you can come to the Expo, because then to meet your peers, but it is outstanding that there is the curling, running, hockey, there's all kinds of sports, if sports is not the way, but there's a lot of scientific evidence too to say that well, I won't quote any data, but the finding your peers and then the sports are secondary to just finding someone who has that shared experience. But hats off to CCB for putting on this Expo, and thank heavens we can have it live today. But it's all about just finding that one connection and then helping each other. And yeah, have the questions, have your loved one, just keep asking more and more people for more and more support.
Yeah, I do know that in the work that I've been able to do with patient advocacy groups, one thing that has definitely been emphasized when discussing these and other issues with policymakers and other stakeholders is, you know what, we need to look past vision loss as a data point, as just a numbers-driven phenomenon. And we need to understand that vision loss is associated, and this is rooted in legitimate research, there's lots of it. Vision loss is associated with depression and experiences of loneliness and other psychological factors. So I know that even in this small world of the work that I've been able to do with the advocacy groups, we've definitely emphasized this to government and other stakeholders, that when we're thinking about bringing a new treatment to market or increasing funding to vision health research, for example, let's think about the other, not just the physical implications of vision loss, but the social and the psychological implications as well. So I think there are a lot of people emphasizing the point that you just made.
Good. I think there's one final question over here that this young lady wants to ask.
Yes, hello. I have a question regarding cataracts. I wonder whether there is any alternative treatment other than surgery.
I'm sorry, other than?
Other than surgery.
Yeah, but what?
Cataract.
Oh, for cataract?
Yes.
No.
Okay.
In a word, that's easy.
Make you feel good, because last August I had cataract surgery on both eyes.
Okay.
It works.
I'm busy trying to negotiate the system right now to get cataract surgery for my wife, who needs it. It was diagnosed last week.
Okay.
So I was saying.
Life-altering for me. At both eyes.
I can give you a perspective on it, though. I spent almost a lifetime, my first lifetime, working for a company that made implants for cataract surgery. So I was very much involved with cataract surgery. When I first started, cataract surgery was a major surgery. It took an hour or two. People had to lie still with sandbags around their head for 2 weeks following surgery. You had thick glasses. You didn't have lens implants. Lens implants have totally revolutionized things, and the equipment that's used for cataract surgery has made surgery very, very simple. Cataract surgery today takes 15 minutes. Generally, people see better afterwards, see better than they did before they had cataracts, because you can get lenses that will correct your vision, like our friend Mr. A here. he has distance vision in one eye and close-up vision in the other, and his brain allows him to switch from one to the other without any
I'm
trouble.
bilingual.
So I think cataract surgery is a miracle. It's turned a major disease into something that is really quite straightforward, and we have two cases here that can speak about it a lot better than I can.
Thanks very much for the question. I'd like to thank everyone for attending in person today and for those that were virtually present. The Toronto Visionaries chapter of the Canadian Council of the Blind would like to thank the Expo Forum's participating sponsors, Allergon, Accessible Media, AMI, Bausch & Lomb, Bayer, Canada, Novartis, Roche, and Via Rail Canada. Events like Experience Expo and this forum could not have happened without the support of those people. We'd also like to thank and give a big shout out to our generous hosts for our Experience Expo forum, the Miles Nadal Jewish Community Center. They have been absolutely great with us, not only this year, but in past years as well. And we look forward to coming back next year. With that, I would like to thank our panelists, Mr. John Adams, I'm going to forget the doctor for a minute, Mr. Keith Gordon, Ms. Sarah Shephard, and Mr. Chad Andrews. Thank you very much. I really appreciate it. The Canadian Council of the Blind thanks you for participating, and who knows, there'll be other roads to cross. Thank you, everybody. Look forward to seeing you next year.